My name is Misra, and I'm a gastroenterologist with Borland. I also do research at our research division, which is on-core Borland clinical research. And the microbiome and C. diff are my areas of interest. So I'm very excited to be here and present uh, this topic to you. And the presentation itself will take about 15 to 30 minutes. It will be a broad overview of the subject. And then I'd love to answer questions. I always find that I learn so much from my patients. The questions they ask, they expose gaps in our knowledge. So I'm actually looking forward to a lot of exciting questions, and we'll use the best science to answer it for you. I'd like to start by just telling you why I became interested in C. diff. So I've been a gastroenterologist, Borland Clinic for about 30 years. And about, I think, 12 or 13 years ago, infectious disease physician's mother-in-law got infected with C. diff. She was a very healthy 70-year-old woman who got repeated C. diff. And despite multiple courses of antibiotics, we could not cure her. And he Googled fecal transplant, and he said, can we try this? This seems to work in some studies that are published from Australia. And that you're an infectious disease doctor. If you think it should work, then I looked up the data and I looked up the protocol, and we brought her in, and I did my first fecal transplant on a Friday about 12 years ago. And this lady had had persistent diarrhea for 3-4 months. Everything went well. She went home. And then I said, maybe I should call her over the weekend. But then I realized, I don't want to call her. She'll call me if there's a problem. She has my cell phone. And then Monday morning, I come to the office, and there's a phone call from her. And she says, Dr. Misra, I'm constipated. She's had diarrhea every day for almost 3 months. And after the transplant, she went to the other extreme. And that's when I realized this treatment works. In other words, replenishing the healthy microbiome is maybe the most effective treatment for C. diff and for many other infections. And that kind of got me started on Clostridium difficile infections and in fecal microbiota transplantation. And in the last decade, we have come really far. That was kind of DIY, do-it-yourself kind of days, where we'd get the stool from a donor, and then we prepare it and then put it during a colonoscopy. Now we have 2 FDA-approved drugs, and we have some exciting clinical trials that we're doing. So I'll be glad to share that information with you. But the excitement that I remember from that day more than a decade ago is still with me. This is my area of interest. So I'm looking forward to speaking to you. So what is C. diff or C. difficile? C. diff is a short term for a bacteria called Clostridoides difficile. And difficile actually means difficult. It's actually a Greek version of the word difficult. And why was it difficult? It's not because it was difficult to treat, but because it is very difficult to culture. It is impossible to culture this bacteria, and that held back research on it for a long time. So it has been around with us since antibiotics were discovered in the 50s and the 60s. And as antibiotic use increased in the 2000s, the incidence of this infection rapidly increased, and it became an epidemic. The last year we have data for, I believe, is 2024. There were 500,000 new cases reported in the United States and 30,000 deaths. It is actually the most common hospital-acquired infection and complication in the United States. And C. diff is a very unique bacteria in the sense that it forms these spores. So spores are resistant forms of the bacteria, where the bacteria is covered by a very resistant membrane, which antibiotics don't penetrate it. So we can get rid of the bacteria, but we cannot get rid of the spores. And that's what makes it so difficult to eradicate. And we know that about 10% of nursing home and hospital patients are colonized with this bacteria. Being in a hospital and getting antibiotics are the major risk factors. What happens is you see a patient with C. diff, you give them appropriate antibiotics, they get better. But about 25% of those patients will lapse. That means that they will have a recurrence after the first attack. After the second attack, that goes up to about 35%. And after the third attack, that's 55 to 60%. In other words, we can get rid of the infection, but because we cannot get rid of the spores, the infection keeps coming back again and again. And this is the major problem that fecal transplant solves: recurrent infection with this bacteria. So who gets C. diff? Well, the two major risk factors are antibiotic use and hospitalization. So if you have used an antibiotic, and the high-risk antibiotics are the broad-spectrum, strong antibiotics like Cipro and Z-Pak, if you have used an antibiotic for 30 days, you have a very high risk of infection. If you have been hospitalized, you can acquire these spores and you're at high risk. There are other risk factors, for example, being older, getting chemotherapy, having cirrhosis, having Crohn's disease, or ulcerative colitis. But the two main risk factors are use of antibiotics, especially strong antibiotics, and hospitalization. So when you get an infection, the spores survive the treatment. And the way the bacteria causes this infection is it goes in and causes severe inflammation of the lining of the colon called colitis. And then it produces toxins that cause the diarrhea. And it produces two types of toxins, toxin A and toxin B. And toxin B is the main cause of diarrhea. And many of the vaccines or treatments are targeted. So in addition to the regular strain, there is now a very hypervirulent strain called O27, which is associated with a high risk of hospitalization, surgery, and death. We see this once in a while, and we treat those patients very aggressively. Okay, so how does this infection present? Well, its main symptom is watery diarrhea. For purposes of research, we define 3 loose stools in a 24-hour period as diarrhea, but it can cause other symptoms, including pain, fever, nausea, weight loss. And sometimes it can lead to a severe enlargement of the large bowel, which is a very serious condition that requires emergency surgery. So how do you diagnose it? Well, first is you need a good history and physical. That means you have to talk to your patient and examine them, because there is no reliable test even today to distinguish patients who just carry the bacteria versus patients who have the active infection. There is no reliable test to tell us who has the active infection and who's just carrying the spores. So it's very important to get a good history and rule out other causes of diarrhea. And the testing is a little complicated, but basically you collect a stool specimen and we do what is called a 2-step test. And this is currently recommended as the diagnostic tests to diagnose C. diff. So when you suspect the infection, you do a good history and physical, you collect a stool specimen and diagnose the infection. So you've seen the patient, you've done a good history, you've diagnosed C. diff. How do you treat it? There are 3 main antibiotics that treat C. diff. The metronidazole or Flagyl is no longer recommended, even though primary care physicians use it a lot. It is moderately effective and it's very inexpensive, so it is used a lot, but our infectious disease societies don't recommend it. The 2 main antibiotics that treat C. diff are fidaxomicin and difficile. In addition, it is important to stop the antibiotic that caused the infection in the first place. Hydration is very important. Nutritional support is very important. And very rarely we give Imodium to slow down the diarrhea. Infection control includes common sense precautions, cleaning the bathrooms, and avoiding contact. Remember, patients with diarrhea are very infectious. Patients without diarrhea are actually not very infectious. And if you have severe symptoms, we typically admit you for inpatient treatment. Okay, so you have a patient, you've diagnosed them, you've treated them with appropriate antibiotics, they get better, and then they have a relapse. This relapse can happen within 2 weeks, but most relapses happen in 8 weeks. That's kind of the magic number. So if you have a first relapse, you can retreat with either fidaxomicin or vancomycin, but give a very prolonged course followed by a taper. For second recurrence, again, you can do a prolonged course or taper, but at the second recurrence in the United States, most people would start looking at replenishing or replacing all the healthy bacteria that have been lost and are responsible for the recurrence. And there are basically 4 options we have. One is VOWST, Ribiota, do a transplant through a donor bank or open biome, or do a transplant through donor stool. I'm going to briefly touch on each one of these. Okay, so VOWST is an FDA-approved treatment. It was approved about a year and a half ago, and we did some of the pioneering research. It is the purified spores of a group of healthy bacteria called firmicutes. And you treat the patient, then you give a mild laxative, and then it's just 4 capsules daily for 3 days. It's very safe. In other words, as you can see, patients can have minor side effects like bloating or constipation, but so far, no major side effects have been reported. Its only downside is that it is very expensive, and insurance coverage is very spotty. But it is an FDA-approved drug with over 80-85% success rate in preventing the recurrences. The second treatment that was approved by the FDA is called Ribiota. This is basically a formulation of healthy bacteria, which is given as an enema. It is typically administered in the office. Again, it has minor side effects, but no major side effects. It is very expensive, but less so than VOWST. In my practice, most patients are hesitant to use enemas. As gastroenterologists, enemas are part of our lives. We don't think it's a big deal. But patients are reluctant to use this. But it is a very effective and very safe treatment. And if covered by insurance, the cost drops. The third option is to do fecal transplant. This is the first kind of wave of fecal transplant treatments, and it has been done thousands of times in the United States and all over the world. I used to use a bank called Open Biome. Believe it or not, there is actually a stool bank in Boston where they have healthy, usually Harvard, MIT students who are very healthy. They are screened blood and stool, and they donate stool, and it is purified. There's no stool, there's just bacteria. And then they put it into either an enema or a capsule, and it can be administered by mouth, through a nasogastric tube, or colonoscopy. It is actually very effective. The success rate is above 95%. And just like other treatments, it has no major side effects. This is not covered by insurance, but it is, compared to the FDA-approved treatments, is quite inexpensive. And recently, because of some regulatory issues, Open Biome has put a freeze on sending donor stool. But this can be done from a donor stool for somebody you know. The process is very cumbersome, so we're doing less and less in this. But this is the original kind of fecal transplant treatment, very safe, very effective, and compared to current treatments, very inexpensive. Okay, so that is kind of a broad overview of Clostridium difficile colitis and its treatments. But in addition to these treatments, at Borland Clinic, we are doing 2 clinical trials. You can go to our website or to clinicaltrials.gov. Both of these trials are listed there, and we are investigators for this 2 products. The first is actually, again, a capsule of healthy bacteria, which is administered over a 14-day course. And we are currently enrolling patients for this trial. You can get a lot more information on this from clinicaltrials.gov. We're also excited to offer you a vaccine. So if you have one C. diff episode and you fall in a higher risk category, instead of waiting for another episode, we can now administer this single dose vaccine, which is given either as a shot intramuscularly or intravenously. The choice is up to the patient. And then we follow you to see what you have, if you have a recurrence or not. And we are currently enrolling patients for this trial. So if you are interested in either one of these trials, you can email, text us, go to our website and fill out a jot form, and we will get back to you.